Anatomy of the lungs and pleura. Identification of the side of the lung. If you are given a lung and asked the question whether it's left lung or right lung, even though there are differences between the left lung and right lung when it comes to the number of lobes and the impressions on the medial surface, you go by the basic rules rather than going for the number of lobes and the impressions on the medial surface. Look for the hilum, which is on the medial side, and look for the curved, smooth posterior surface, and look for the diaphragmatic surface or the apex. With these three things, you can say whether it's left lung or right lung. A rule of thumb that you can remember is if you make a fist with the right hand, it represents the right lung. And similarly, if you make a fist with the left hand, it represents the left lung. So in that example, the area of the wrist represents the hilum of the lung. The dorsum of the fist represents the curved, smooth posterior surface of the lung, and the side of the palm and the bent fingers represents the anterior surface of the lung. This is true for both right and left fists. Lobes of the lung. Right lung is divided into three lobes, namely upper lobe, middle lobe, and lower lobe, by an oblique fissure and a horizontal fissure. Left lung is divided into two lobes, namely upper lobe and lower lobe, by an oblique fissure. Hilum of the lung. The parietal pleura covers the structures at the hilum of the lung on the medial side and becomes the visceral pleura, getting attached to the surface of the lung. The pleura forms a double-folded pulmonary ligament below the hilum of the lung, which allows movement of the structures in the hilum up and down during inspiration and expiration. The main structures in the hilum are the bronchus, pulmonary veins, and pulmonary arteries. The bronchus lies posteriorly. The pulmonary arteries, which are shown in blue color here, lie anterosuperiorly in the hilum. Veins, shown in red here, lie anteroinferiorly. This is a diagram of the airway. In this diagram, you can see the trachea divides into left and right main bronchi. The main bronchi are also called principal bronchi or primary bronchi. Each main bronchus is divided into secondary bronchi or lobar bronchi. On the right side, the right primary bronchus or the main bronchus divides into right superior lobar bronchus, right middle lobar bronchus, and right inferior lobar bronchus. These are secondary bronchi. You can see an intermediate bronchus here on the right side, which lies between the primary bronchus and the secondary bronchi. On the left side, the primary bronchus divides into a superior lobar bronchus and an inferior lobar bronchus. You can also see on the left side there is a lingular lobar bronchus. Lingular lobe is a lobe on the left side hidden in the superior lobe. Some anatomists believe that this lingular lobe is actually the middle lobe of the left lung pushed into the superior lobe because of the presence of the heart more towards the left side. Each secondary bronchus is divided into several tertiary bronchi. The right superior lobe bronchus, you can see here, is divided into 3 tertiary bronchi. And the right middle lobe bronchus is divided into 2 tertiary bronchi. And the right lower lobe bronchus is divided into 1, 2, 3, 4, and this is the fifth one. This is the branches of the fifth one. Fifth tertiary bronchi, 5 tertiary bronchi in the right lower lobe. On the left side, the left superior lobe has 2 tertiary bronchi. The lingular lobe has 2 more tertiary bronchi, and the lower lobe has 1, 2, 3, and 4. Fourth one, tertiary bronchi. Bronchopulmonary segments. The area of lung supplied by a single tertiary bronchus is called a bronchopulmonary segment. Each bronchopulmonary segment has its own artery, vein, and lymphatics. They are structurally separate, functionally independent units of the lung separated from each other by connective tissue septa. Because of this arrangement, they can be surgically resected without much damage to the surrounding tissues. Now we will take a look at the bronchopulmonary segments in the left and in the right lung. If you look at the right lung first, you can see there are 10 bronchopulmonary segments in the right lung. And in the left lung, there can be 8 to 10 bronchopulmonary segments. If you look at the right side again, in the upper lobe, you can see there are 3 bronchopulmonary segments. The apical segment, posterior segment, and the anterior segment. Middle lobe on the right side has got 2 bronchopulmonary segments, the medial segment and the lateral segment. The lower lobe has got 5 bronchopulmonary segments. There is a superior segment and there are 4 basal segments, the anterior basal, posterior basal, medial basal and lateral basal segments. Altogether, it makes 10 bronchopulmonary segments on the right side. On the left side, if you go to the high end, where there are 10 bronchopulmonary segments, in the upper lobe, if you see, you can have an apical segment, a posterior segment, and an anterior segment, just like on the right side. Then, the lingular lobe on the left side has a superior segment and an inferior segment. If you compare it with the right side, where there is a middle lobe instead of lingular lobe, the 2 bronchopulmonary segments that were there on the right side in the middle lobe was medial and lateral segments. But on the left side in the lingular lobe, it is superior and inferior bronchopulmonary segments. When it comes to the lower lobe, just like on the right side, there are 5 bronchopulmonary segments, a superior segment and 4 basal segments, anterior basal, posterior basal, medial basal and lateral basal segments. In certain people, in the upper lobe, the apical bronchopulmonary segment can fuse with the posterior segment and form an apico-posterior segment, reducing the number of bronchopulmonary segments to 9 on the left side. Then the anterior basal one can fuse with the medial basal one and form one bronchopulmonary segment, reducing the number of bronchopulmonary segments on left side down to 8. This is the reason for giving this number on the left side, the range from 8 to 10. The arrangement of pleura the arrangement of the pleura should be understood like a balloon filled with little amount of water. If you push your fist against that balloon, two layers will be created around your fist. One layer will be attached to the surface of the fist, which is like the visceral pleura, and there will be a second layer which is connected with the first layer surrounding the first layer, which is the parietal pleura. So this is visceral pleura and this is parietal pleura. Then in between the two layers there is a fluid which is called pleural fluid, and the cavity between the layers is called the pleural cavity. And the wrist of the hand here can be taken as the hilum of the lung, as I described before. Parietal pleura is firmly attached to the inner surface of the thoracic wall. If one wants to separate it from the inner surface of the thoracic wall, one has to tear it from the surface. Similarly, the visceral pleura is firmly attached to the surface of the lung, and if one wants to separate it from the surface of the lung, one has to tear it off the surface of the lung. The visceral pleura, since it is firmly attached to the surface of the lung, dips down into the oblique and transverse fissures, making it possible for us to insert our fingers or hands through these fissures. The parietal pleura is also attached to the upper surface of the diaphragm. Depending on the area it lines, parietal pleura is given different names. At the root of the neck, it is called cervical pleura. Where it lines the inner surface of the chest wall, that is to say the ribs and the intercostal muscles, it is called costal pleura. Where it lines the diaphragm, it is called diaphragmatic pleura. And where it lines the mediastinum, it is called mediastinal pleura. Usually, the parietal pleura lines side by side with the visceral pleura. In certain places, two layers of parietal pleura lies side by side with each other. At the lower limit of the pleural cavity, the costal pleura lies side by side with the diaphragmatic pleura, forming what is called a recess. In this case, it is called costodiaphragmatic recess. There is a similar recess between the costal pleura and the mediastinal pleura, which is called the costomediastinal recess. Depending on the position of the person, fluid in the pleural cavity, if there is excess fluid, can get collected in these recesses. Most of the time, in erect chest X-rays, if there's little amount of more fluid in the pleural cavities, they can get collected in the costodiaphragmatic recess. The apex of the lung projects superiorly into the root of the neck, above the first rib and the clavicle. Like in any other place, apex of the lung is also covered by the two layers of pleura, the visceral pleura and the parietal pleura. At the root of the neck, the parietal pleura is separated from the structures in the root of the neck by a membrane, a tough membrane called suprapleural membrane, which is attached to the inner border of the first rib and the transverse process of seventh cervical vertebra. Nerve supply of the pleura. The costal pleura is supplied by intercostal nerves. Mediastinal pleura is supplied by the phrenic nerves, and the diaphragmatic pleura in the center is supplied by the phrenic nerve, and at the periphery is supplied by the lower 6 intercostal nerves. Visceral pleura is supplied by the pulmonary plexus formed by the vagus nerve and the sympathetic nerves. Blood supply to the lungs come from bronchial arteries, which are direct branches from the descending aorta, and the bronchial veins drain into azygous and hemiazygous venous systems. Lymph from the lungs first drain into pulmonary nodes, then into bronchopulmonary nodes, which are situated at the hilum, which are also called hilar nodes, and then tracheobronchial nodes situated at the bifurcation of the trachea. Some clinical aspects. When there is inflammation of the pleura, it is called pleurisy. Presence of excess serous fluid in the pleural cavity is called pleural effusion. When there is pus in the pleural cavity, it is called empyema. When there is blood, it is called haemothorax, and when there is air in the pleural cavity, it is called pneumothorax. Now we will see how a pleural effusion is seen in a chest X-ray. In a chest X-ray, fluid is seen white in color. In the first chest X-ray, you can see the left costodiaphragmatic recess is clear. The right costodiaphragmatic recess is not clear. There is fluid in the right costodiaphragmatic recess. You can see the raised peripheral edge of the fluid which is filling the right costodiaphragmatic recess. In the second radiograph, you can see there is lot of fluid on the left side. You can see the upper limit of the fluid here with the raised peripheral end of the fluid towards the parietal pleura, costal pleura. This whole area is filled with fluid. This is a case with air in the right pleural cavity or pneumothorax. If you look at this X-ray carefully and compare the two sides, you can see on the left side there are many bronchovascular markings in the lung field. But compared to the left side, on the right side, the lung field is clearly black without any bronchovascular markings. And you can see a whitish appearance here on the right side, which is actually the collapsed lung tissue. And if you look at the midline where the trachea is, it is not shifted, and the heart is also not shifted. It's in the midline. Diaphragm is pushed downwards. Because of air inside the pleural cavity. In a pneumothorax, Air can leak into the pleural cavity either from the side of the lung or from the external environment. If there is a disease of the lung damaging the lung tissue and the visceral pleura, air from the lung can leak out into the pleural cavity, causing a pneumothorax. Similarly, if there is a stab injury to the chest wall or bullet injury that creates a hole that will bring air into the pleural cavity, creating a pneumothorax. The second example, where the thoracic wall is damaged, is called an open pneumothorax. Tension pneumothorax. Sometimes, when the lung is damaged due to disease of the lung, or the ragged edge of a fractured rib, or the chest wall is damaged due to a bullet injury, stab injury, or a fractured rib, in the area of the damage, a tissue flap can act as a valve and allow air to enter the pleural cavity during inspiration, but does not allow air to exit during expiration. This can build up pressure inside the pleural cavity where the pneumothorax is. That is called tension pneumothorax. In a tension pneumothorax, you can see, just like in an ordinary pneumothorax, there is absence of bronchovascular markings on the affected side, which is the right side in this chest X-ray. And you can see some collapsed lung tissue here with the diaphragm pushed down. You can also see the trachea, which is supposed to be in the midline, has been shifted with the heart to the opposite side. This actually compresses the normal lung on the left side. Tension pneumothorax is a life-threatening condition. If you don't act swiftly, that can lead to death. Needle thoracocentesis or pleural tap. Inserting a needle through an intercostal space into the pleural cavity to obtain some fluid for investigations or to remove blood or pus from the pleural cavity and give immediate relief to the patient is called needle thoracocentesis or pleural tap. Usually, the patient is kept in an upright sitting position leaning on a table, like in the diagram, and the needle is inserted into the ninth intercostal space in the mid-axillary line, avoiding damage to the intercostal neurovascular bundle. Sometimes ultrasound scan can be used to find out the best place to insert the needle and to avoid damage to the lung tissue or the diaphragm with the needle inserted. Thoracocentesis versus intercostal nerve block. When we insert a needle into the pleural cavity through the intercostal space in thoracocentesis, we advise to insert the needle avoiding damage to the neurovascular structures. To damage the main neurovascular bundle related to the lower border of the upper rib, we are advised to insert the needle closer to the upper border of the lower rib. But we need to keep in mind that the collateral branches are related to the upper border of the lower rib. Therefore, you have to go slightly above the upper border of the lower rib to avoid damage to the collateral branches. At the same time, if you want to anesthetize an intercostal space to do a procedure in that area, you need to remember that there is a collateral branch and the local anesthetic agent should be infiltrated not only around the main intercostal nerve, which is related to the upper border or the lower border of the upper rib, but also the anesthetic agent should be infiltrated around the upper border of the lower rib to anesthetize the collateral branch. Otherwise, total anesthesia will not be achieved. Needle thoracostomy. If you detect a tension pneumothorax, you have to immediately relieve the pressure on the affected side. To do that, you insert a large bore needle into the second intercostal space at the midclavicular line. When you do that, the air under pressure in the pleural cavity will rush out through the needle to the outside. That will allow the lung to open up on the affected side. A large bore needle is a needle with a lower gauge. In needles, when the gauge of the needle goes down, the size of the needle increases. You can go to the internet and look for gauge of the needle of a needle to find out. Thoracostomy tube or chest tube. To remove large volumes of air or fluid from the pleural cavity, a thoracostomy tube can be inserted into the pleural cavity through an intercostal space. This kind of patients are usually in a propped up position in a bed, and the air tends to move up towards the apex, and the fluid tends to move down towards the diaphragm and the costodiaphragmatic recess. Therefore, when a tube is inserted, if there is air in the pleural cavity, the tube is directed upwards towards the apex of the lung. And if you want to remove fluid from the pleural cavity, tube is directed downwards towards the costodiaphragmatic recess. As shown in this diagram, the tube connected to the pleural cavity, the other end of the tube connected to the pleural cavity, is dipped in a bottle half filled with water. When the person expirates or coughs, the pressure in the pleural cavity increases, and the fluid in the pleural cavity or air in the pleural cavity tends to get collected in the bottle. The fluid gets collected in the bottle, air leaves the bottle through the other tube. When the person inspirates, the pressure drops in the pleural cavity and fluid in the bottle tends to move up along the tube. The arrangement of the bottle prevents air from the environment getting into the pleural cavity. It should be remembered the bottle to be kept in a lower position than the patient to prevent air from the bottle, the fluid from the bottle entering the pleural cavity. Safe triangle to insert a chest tube is defined. In the safe triangle, its anterior border is formed by the lateral edge of the pectoralis major. Posterior border is formed by the lateral edge of the latissimus dorsi. The superior border is formed by the base of the axilla, and the inferior border is formed by the fifth intercostal space. Aspiration of a foreign body. A foreign body can accidentally enter the trachea. Right bronchus is wider, shorter, and more in line with the trachea than the left bronchus. Therefore, a foreign body coming through the trachea has a higher chance of entering the right bronchus than the left bronchus. If the person is in an erect position, the foreign body that entered the right bronchus has a higher chance of entering the posterior basal segment of the lower lobe because it is more in line with the direction of the right bronchus. If the patient is in a supine position, it's more likely to enter the superior segment of the lower lobe.